Hello, welcome to this presentation on the Introduction to Interprofessional Primary Care and Complex Care Models for the Community Dwelling Older Adults. This is Dr. Sharon Rayner, and in this presentation, we're going to focus on the Impact Clinic. First, we're going to review the Impact Clinic and discuss why and how impact is needed for community dwelling older adults. We're going to take a look at some of the complex needs of older adults and describe how palliative care and hospice is part of health promotion and disease prevention for this population. And you'll have the opportunity to apply the impact model to a clinical simulation experience. At Jefferson, we're very fortunate to have a lot of resources that would allow for the impact clinic. Currently, a lot of those ways that we used to do hands-on impact clinic have been transformed due to the COVID-19 pandemic. However, the experience of the impact clinic and thinking about the vast resources that are needed to provide care to community dwelling older adults, it is important to think about the impact clinic as a digital experience. And so a virtual clinic, impact clinic, is how we can actually provide more comprehensive care to patients and provide an interprofessional experience for students. It's important to think about primary care for older adults since the number of older adults in the United States is growing. By 2020, there is expected to be over 71 million older adults and 98 million by 2060. So by then, older adults will make up nearly 25% of the United States population. Also, we are dealing with multiple chronic conditions. It's not just one chronic condition that we might be managing for a patient, but layering of chronic conditions with episodic needs for care. And this makes the care much more complex. And in some populations, it is difficult for the patient to access specialty care. And so the impact clinic is a very good way that we can provide access to multiple specialists. When we talk about older adults, we're really talking about 65 and older. That is what comes under the Medicare guidelines. However, the American Geriatric Society, for example, will refer to geriatric patients as age 50 and older. But for the purposes of Impact Clinic and thinking about the comprehensive care for older adults, we're really thinking about the 65 and older. And for that population, the life expectancy at 65 for both sexes is about 20 years. And this is important because we really want to think about the quality of life that people are having as they age, and we want them to age well and have access to care that can make their quality of life much better. One of the goals of the Impact Clinic is healthy aging, and everyone's going to age well or age healthy in their own way. And what might be health and wellness to one older adult may not be available or accessible to another older adult. And so we need to think about aging, a healthy aging or aging well, as a very individualized experience for patients. The Impact Clinic really allows an individualized yet comprehensive approach to care of the community dwelling older adult. The model uses an interprofessional practice model for aging and complex treatment, and the team approach is highly utilized using an interprofessional team. Each member of the team participates in the patient's assessments and works together to develop individualized patient care. And that does sometimes include the family, but really taking into consideration what the patient wants, what the patient needs. That's how we individualize the care. And it really targets those complex needs of the community dwelling older adult in terms of their safety, their health and wellness, and their relationships with their families. Now, if we think about a case, and this may be a case that you will see in a simulation experience, we can apply the impact clinic. For example, if an older male or female might be coming home from rehab or may have had some kind of an episode or a exacerbation of a chronic illness and has been hospitalized and coming home, we need to really look at this comprehensively. So how can this patient again pick up and age well and be safe and live by themselves at home? So for example, in this case, the patient may live alone. For one example might be they had a TIA or fell or had some kind of injury in their apartment, and on top of that they may have very complex needs. So they may have health needs that need to be addressed, such as maybe they smoke, maybe they drink, maybe they have other chronic illnesses like heart failure or high blood pressure, high triglycerides. All of those chronic diseases, possibly even diabetes, that they're managing on their own with the help of their healthcare providers, but they're managing this on their own at home. And then on top of that, they have an injury or a fall. And then in addition to that, there may be social needs. They may have family. They may not have family. They may have family that's out of town. They may have family that's not involved. They may have family that they're at odds with. Maybe the family does not want them living at home. So there's a lot of social needs that are layered on top of those complex health needs. And they may also have, we talked about geriatric syndrome so far in this course, and they may have great needs for safety and making sure that they are able to live in the environment in which they are, but do so safely. And so what needs might people have when they will get discharged back home? And maybe this is from an acute care facility, because not every person wants to go to rehab. I've had plenty of experience where patients come home and they would have really benefited from maybe 6 days even in a rehab, but they don't. They want to come home. They want to be back in their environment. And or it may be that the person is coming back from rehab. They did spend some time in a rehab facility and now they're discharged at home. So you'll see a lot of different scenarios for this, but the needs of the patient and the type of assessment and determining what this patient's individualized plan of care is all very similar. So one of the ways that we can use the Digital Impact Clinic is to use technology. It can help us connect to other professionals. It can help us connect with other family members or other agencies like home care nursing, for example. We might wind up calling a pulmonologist from the patient's home. This is in the ideal world of a fully functioning impact clinic. I can tell you from my own experience, this doesn't happen very often. I've tried to actually get a pulmonologist on the phone to talk about a patient's medications, and it just didn't happen during the time that I was seeing the patient. But if you can, it is a very good way to help patients who are alone, who can't make appointments, to have this impact clinic set up where you can have an appointment time and actually access the pulmonologist right there during the patient's visit. Other things that we can do is to have consultations. So that may be hint if somebody's coming home after a fall, physical therapy, occupational therapy, other kinds of consultations that might come to mind, like dietitian, for example. And then also close follow-up. So Medicare guidelines right now for home-based primary care is every 4 weeks patients can be seen. There is one caveat right now that we cannot have two providers see the patient on the same day, because only one provider can be paid per day. Now there are some policy initiatives to look at that, and hopefully that will be changed in the future so that a real functioning impact clinic can happen. But nevertheless, we can work around some of these things and really try to access a comprehensive team for the patient. And in the past, sometimes these very complex patients would be seen maybe every 3 months, every 6 months. And because of the nature of their chronic illnesses and to really decrease the number of hospitalizations and so forth, now we are able to see patients every 4 weeks at home. So the way the Impact Clinic works, or the protocol for Impact, is that the patient has a prearranged appointment. You have this set up with the patient and or with the family, or it could be the patient with their family all at the same time. And you pretty much go through your HPI. In an initial interview, you're really determining the plan of care for this patient. So each team member theoretically would see the patient and then determine a plan of care after they've had a team discussion. So every, say, specialist would see the patient. It could be primary care, a family nurse practitioner, the PT and OT would actually see the patient and weigh in. The patient might say have CHF, so they would have a cardiologist also weigh in, or a pulmonologist if they have like COPD. And then there would be a team discussion, and then this interprofessional assessment would happen. And then they would determine a collaborative care plan for the patient, which would be the working document or the plan of care. This would be iterative, and so that every time something would change with the patient, or if there was some one specialty that felt something needed to be addressed, the team would reconvene and then work through another team discussion to see what needed to change. This team discussion may also branch out. So in other words, one of the things when you're looking at your interprofessional group that you would like to assemble for a patient for an impact protocol, you might think of some other additional providers that need to be involved in this team discussion, and really this person would need to weigh in on a collaborative plan of care. So for example, if you're seeing the patient, maybe you decide this patient really does need home care, maybe home care nursing for medication management, for example. And so then you would pull in a home care nurse. Or if there's a need for hospice and palliative care, and then we'll talk about that a little bit more as well. One of the most important things when you're seeing a patient, when we have the Impact Clinic and we're able to actually be in the person's living environment, in their home, we can inspect for safety first. So what are we going to look at? Where are we going to look? We're going to do a good environmental scan of the apartment or their living situation. And this is really important, although if the patient is coming into the office or into the health center to then be involved in the Impact Clinic, this makes the environmental scan much different. Although it has been determined that the patient does need an environmental scan, and then maybe the PT, OT, and the primary will go back out to the house and look or the apartment and look to see what needs to be addressed in that environment. So it happens, it may not happen as neatly, I should say, as you'll experience sort of this Impact Clinic when you do your intensive, but it all can happen. So safety is really crucial, especially for older adults, especially because of the high rates of fall and the high rates of death associated with falls. And so an environmental scan is really always appropriate. And you want to think about strategies to address, because not many older folks are really willing to change their environment or change much of anything. So they may have been living in their house for 50 years and that's it. That's the way it is. I had a neighbor, she unfortunately died of COVID, but she would take herself up the steps, 12 steps every night and go to bed in her apartment, in her bedroom. She did not have air conditioning in the home. It was an older home. And she never wanted air conditioning. And so on these super hot days, you can imagine what her house felt like. And she was just settled in her ways and wouldn't change anything, in spite of her son and neighbors and everybody involved. And that was just the way she was. Unfortunately, her son then did convince her to go into a facility, and probably, I guess, a year or so later, COVID hit, and she died of COVID. So super sad story, but you have to be very respectful of an older person's environment, because that's their environment. When you go into the home, you may find hazards and things that really need to be changed, but it is their home, and they have to be the one to make the final decision. Okay, so always think about strategies to address what you're looking at or what you're finding that could impact this patient's environment. So think about who might be on the team. So think about the case so far. Somebody might be coming home from the hospital or rehab. You definitely are going to start thinking about who might be on the team. So I want you to think about this before we have the pre-brief for the simulation. Physical therapy, occupational therapy, if the patient had a TIA, speech therapy, those are pretty obvious things. So start to think about who else. Read a little bit more on complex care, and when you might think about referring somebody or need a specialist if the patient is coming back home. And also, I want you to think about palliative and hospice care. And would this be something that you would bring up on the first visit, on that initial plan of care visit? And you're probably thinking, well, that depends. It's going to depend on what you find. And that's true. And it's also going to depend on the patient, when you actually talk to the patient to determine their goals. And so just something to think about in advance. So palliative and hospice care are part of health promotion, disease prevention. It's a quaternary prevention. It's really talking about not taking unnecessary steps to prolong life. It is taking action to identify the risk of over-medicalization, to protect patients from new medical invasive procedures, and it's really to let the patient and their family make decisions that that they feel is right for them at the end of life. And I just recently had an experience where I had a patient with dementia, end-stage dementia, and I found her bradycardic and having a very irregular heart rate at home. And I sent her to the emergency department. They wouldn't go 911, but the husband did agree to take her. And when she was there, they had to get 4 security guards to hold her down, try to even draw any blood or get an EKG. And at that point, the family just said, that's enough. We're not doing any more hospitalizations. And I just saw her again today, and we signed a DNR, DNH. And that is what was most appropriate for that family. And so we need to think about that. And, depending on how the person looks when you're seeing them for the first time, it may be very appropriate to talk about that, or talk about that as a strategy maybe later on. And sometimes when you're talking about palliative and hospice care, you really need to do a lot of education. So patients and families may not understand what palliative care is, may not understand hospice, or they may think, well, why can't I be on hospice? I have this, I have dementia, it's not going to get better. Why can't I be on hospice now? And so a lot of times you do need to spend quite a bit of time educating patients and families about this level of care. And this slide just reminds you of the 5 levels of prevention, and it's really important to remember those, and really they all would apply to some regard in the Impact Clinic. There's certainly a growing need for interprofessional primary care models like the Impact Clinic, as new future family nurse practitioners. You really hold great promise for this growing challenge, to meet this growing challenge of complex chronic disease management. And as I touched on in the beginning of this presentation, we really need some policy initiatives, some research on this, really a lot of primary care reform. These are not necessarily patients, a population that does very well with telehealth, but given the right situation, and bringing the digital impact clinic to life, patients can do very well and have access to providers that they wouldn't otherwise have. And so you're the generation that we're going to look to drive innovation and really make the digital impact clinic come alive. I thank you very much for listening. I'm very much looking forward to the Impact Clinic for your intensive. If you have any questions in the meantime, please feel free to email me at sharon.rayner@jefferson.edu. And I look forward to seeing everyone soon and running the Impact Clinic. Thank you.